Is 10:02 and we are called to order for the Board of Health meeting. Our first item of business this morning is to approve the minutes. Do we have any corrections to the minutes?
Hi, good morning. Just a personal one. My name is spelled in different ways on different pages, but there's no E in my last name. So start out correct and then that's repeated with an E.
So it's F-O-R
M-A-N.
M-A-N. Noted, and we will make that correction.
I didn't think there were any other substantive issues.
Move approval of the minutes.
I have a second. And approved.
All in favor?
Aye.
Aye.
All right, so we move on to the resolution to amend Articles 11 and 13 of the New York City Health Code regarding reportable diseases, conditions, and laboratories. We have the notice published in the City Record on March 19th, and Dr. Varma will give a presentation that includes a summary of the public hearing held on April 23rd.
Wait, hold on one moment. Slide start. Okay, good morning. So I'm just going to provide a brief summary of the proposals that were made at the last board meeting, and then review the major substantive comments that were received from the public. Just very briefly, we had a number of proposals, but they can be grouped essentially into four major categories. The first was to add pharmaceutical sales to syndromic surveillance. The second was regarding being more specific and detailed about the authority of the health department to isolate infectious individuals. The third was to add specific data elements to the laboratory results that are already being reported. And the fourth was to add additional lab results that we would like to be reported to the department. The rulemaking process, as you know, the board approved publication of these proposed rules on March 11th. We held a public hearing on April 23rd, and we also received written comments. In total, received 10 total comments. Of these, 9 were written and 1 was oral. 4 of them were representing pharmacies, and 6 of them were representing laboratories. So now I'll go through each of the major proposals that were made, as well as the comments that were received. The sort of most notable changes regarding the issue of pharmaceutical sales for syndromic surveillance. We received a number of different comments, as I mentioned, from pharmacies, as well as held an actual meeting with representatives from all of the people that had actually written in notifications. What was discussed was there was a concern by the large retail pharmacies about the burden of reporting. It turns out that when they are voluntarily doing something, it turns out to actually be easier than when there's a regulatory requirement. It has to do with the issue of them having a whole regulatory compliance section, which needs to then provide additional oversight when there's actually a requirement of reporting. There was also expressed a willingness to actually, for those large chain pharmacies that are not currently reporting, to participate in reporting. So we agreed with them that we would that there was not an urgency to enact this rule at this moment, and so that we would actually proceed down a path of trying to get more pharmacies to report voluntarily, but express that we will in fact revisit this proposal and put it before the board again if in fact that we find that voluntary reporting does not increase the volume, quality, and representativeness of data that we're going to receive. And those discussions are actually ongoing right now with these pharmacies now about voluntary reporting. The next major category was clarifying the authority of the health department to isolate, to order healthcare providers to isolate people with communicable diseases of public health importance. A comment was raised, I believe, by Dr. Richardson, maybe specifically about whether or not, why this rule was only being applied to the attending physician and not to other people. So we actually have proposed modifying the language so that it is more expansive. And the revised language you can read there says it shall be the duty of the attending physician or the person who is in charge of the hospital, clinic, nursing home, or other medical facility. So we hope that this will address the concern about it not just being the physician's responsibility, but actually the administration who is responsible for that institution as well. The next was we received a number of comments. Some of these are relatively minor, so I did not include them in the PowerPoint. A lot of them are technical clarifications regarding data elements to be included in laboratory reports that we are currently receiving. So one set of comments had to do with the burden on laboratories needing to maybe change either electronic or paper forms that they use, and the transition time for enacting this rule or adopting this rule into the regular practice, and concerns about their laboratory information management system. We realize, of course, that we're adding a regulation, so by definition there is some additional burden being imposed. Our sense from the comments that we received and in the discussions we've had with large commercial laboratories is that we do have an established process by which we, even after the rule takes effect, there is a running period where we provide assistance to laboratories, both us as well as New York State, on ensuring compliance with laboratory regulations. Laboratory regulations are constantly being modified and changed over time, so we don't believe that this represents an undue burden, particularly because we do provide this assistance to upgrade their systems, and that there is a standard messaging format that is available that all laboratories are moving to, some faster than others. The next was related to this is the issue about reporting pregnancy status. As we discussed before, for specific infectious diseases, particularly hepatitis B and syphilis, it is important for us to receive not just the information about the laboratory result, but about anything that is known about pregnancy. Currently, we receive reporting related to patients for whom pregnancy status is absolutely known. There was a positive pregnancy test ordered at the same time that a hepatitis B or syphilis result returned positive. Some laboratories wrote concern that they were concerned about us requesting that pregnancy status be reported because it might require them to review the patient's medical record. And our point was that, in fact, already laboratories are complying with the rule without having to review the medical record. We are adding the requirement that we also want pregnancy status if it's probable. Specific conditions you can see listed up there, whether an ICD-10 code is accompanying it, whether the specimen was ordered from a labor and delivery unit, or whether a prenatal testing panel was ordered at the same time. And I think it's important to emphasize that it's not required for a laboratory to look for this information. It's only required to look for it within its existing records. In other words, they don't need to call the provider or go to other medical records. If they can ascertain pregnancy status within their medical information system they have immediately available, then it's expected that they report. And if not, it just gets reported as being an empty result. There was comments received both regarding this proposal as others about the other jurisdictions not requiring these data amounts. I don't need to educate you that we impose our own rules based on our own priorities, and so we don't necessarily regard that as a concern. New York City priorities are established for ourselves, and therefore we impose rules to try to meet and achieve those goals. There was a few comments related to why this is overlapping with other health code regulations. We specifically needed to differentiate or clarify that, in fact, there are rules, as you know, for provider reporting that are covered under Health Code Section 11.03. Laboratories have a separate reporting requirement that is critical for us to follow and track infectious diseases. There was also comments about laboratories not routinely collecting phone numbers. Again, I just wanted to emphasize this point that we are not expecting laboratories to look and seek more information than they already have. Rather, we're asking them to report only on data that they currently do have in their possession. There were some questions raised about the requirement regarding TB reporting. As you remember, we were asking for results of negative tuberculosis tests to be reported to us if the patient previously has had a positive test for tuberculosis. This allows us to expedite our follow-up of patients, including helping providers to discontinue treatment if it's no longer indicated. Again, there was questions about the burden that is potentially imposed on laboratories, needing to track specimen results after an initial one was positive. We already know that hospital laboratories have a very easy way of tracking this, and a lot of our reporting does come from hospital laboratories, so we don't view this as an undue burden. They use their specimen numbers linked to the patient identifiers, and it's very easy for them to search for this. And for other laboratories, there are other requirements for them to search for results by individual patients, so we don't believe that this is very inconsistent with what they already do. There was a question of clarification about cases that are clinically diagnosed. And again, just to clarify, and this is clear in the health code, this is only for people that have a confirmed microbiologic diagnosis. So if a physician makes a decision to treat, and that person has negative results, it's not required that those be reported. It's only for those patients for whom there is initially a positive microbiologic laboratory result indicating tuberculosis. There was a question about the time limits in terms of do they report in perpetuity for the rest of this person's life. So we have proposed to amend the health code language to specify that we're only looking for negative results ordered within 1 year after initial positive result. So if a positive result is ordered today, or a positive result returns today, then up until 1 year after this point, laboratories will be required to report any positive or negative laboratory results for that same person as they relate to tuberculosis test results. The last set of comments was related to our requirements regarding viral hepatitis, both hepatitis C and hepatitis B. There was one comment made about the burden of reporting hepatitis B surface antigen results and surface antibody results for children anywhere from 0 up until 5 years of age, and the need to calculate age. We actually, even before proposing this amendment, had already contacted 2 of the largest volume providers to the health department. These are large commercial laboratories, and they estimate that they report about this would cover about 6,000 tests per year. But they said this does not represent an undue burden because they already do reporting for certain conditions based on age. And so we've concluded that though there may be smaller laboratories for whom they have to re-engineer their systems to allow them to calculate age, that for the vast majority of laboratories or laboratory results we will be receiving, this is not an undue burden. We also received a comment from blood banks, which actually perform hepatitis C RNA testing as a method of screening large volumes of blood samples to keep the blood supply safe from infectious diseases. So we have in fact amended our rule because our objective is to obtain RNA results for patients for whom previously had antibody tests positive. In other words, patients for whom there was evidence that they've previously been infected. So we are exempting blood banks from the requirement that they report negative RNA testing since they are screening huge volumes of low suspicion patients. So I think finally we received sort of a general comment, and this sort of gets to some of the themes that we had about laboratory reporting. The clinical laboratories reported they're faced with less money, fewer staff, and that the health department is shifting the burden from its own area of responsibility to that of laboratories, and so that the laboratories have to incur that cost as opposed to the health department. I think our stance on this is very similar to what we've mentioned before. The laboratories are a critical and independent source of reporting, and we've long relied on laboratories to be public health reporters, and we have made, we believe, a strong case in our statement of basis and purpose about the importance and health benefit that comes from more accurate, complete, and timely reports. Thank you.
Thank you, Dr. Varma. Do I have questions from members?
Thank you. I have a question about the last slide, actually.
Yeah.
Your argument sounds pretty convincing. I'm actually trying to think, I don't understand the comment. I'm trying to understand the comment. How could the health department do this? My understanding is you're trying to get reports from sources that you don't really have your fingers in. So I'm just trying to understand, is there something to this comment that I'm not seeing?
Yeah, I think it gets to this issue about requirement. I'll use the example, for example, of age. One of the reasons that we want negative results reported, so negative results and related to age restriction. One of the reasons we want negative results reported to us is that currently one of our biggest responsibilities for people in whom we suspect perinatal hepatitis B infection, we need to follow up with providers aggressively to get negative results, because right now only positive results are reported. So in fact, we are trying to make our job easier by having laboratories report negative results to us, as opposed to us having to actively call the laboratories and the providers to get those results. We would argue that this isn't a question about ease, it's a question about efficiency of public health work. We don't believe that it represents an undue burden on the laboratories, yet it would have a potentially positive impact on the health department. The same is true with negative reporting, for example, for tuberculosis cases. If we would want to get those negative results, which we try to do now, we are constantly trying to find the provider, find the patient, find the laboratory result. And here we're arguing that there is a public health value in then reporting that to us proactively.
That makes sense, thank you.
Are there, Susan?
Hi, thanks, Dr.
Dr.
Varma.
Zitzman.
It's okay. I'm just trying to understand the implications, if any, of withdrawing the proposal to have pharmacies report for syndromic surveillance purposes. So some of the comments from the pharmaceutical industry were, first of all, that there are already state regulations, and by adding this to the New York City Health Code, it would be duplicative. So could you tell us about that? And also, some of the large chains say that they already report to us, and I'm wondering if you've looked at that data and if it's instructive in any way. Thanks.
I don't know the answer to the state overlap question. I don't know, Martha, or whether anybody has any.
I don't think there is any state report.
I'm not aware that there is any state requirement as it relates to pharmaceutical reporting. So we can clarify that. So let me answer the second question then now is, so when we described our syndromic surveillance system during the last board meeting, that is the data that we currently receive, which is really from 2 large chain pharmacies. And so we believe that that data is valuable, and we gave several examples both for endemic disease control, for non-infectious diseases, and for emergency responses, for which we have been able to take public health action based on that. Our sense, however, is that there is more data out there that could help us to refine those, to improve the quality of that. One issue is representativeness of the city of New York. Most of these large chain pharmacies are concentrated in Manhattan. They don't actually cover so much about the outer boroughs, so getting more data can actually help us with that. We also think that we don't know about patient demographics, about whether the same populations are going to each of them. So we do believe that there is value to be gained by expanding the number of pharmacies that report to us. One of the challenges that was raised was this issue about regulatory compliance, and that by having it be voluntary for them, it actually is easier for them to do, which is in contrast to what some of their actual technical people had said when we first started talking with them. On their technical side, they thought it was easier for them to have a rule so that they felt like they needed to do it, but in fact, you talk at the corporate level and they say, in fact, it's much easier for them to sign a voluntary agreement. Another issue that we haven't resolved fully, and that came up during our discussions with them, was the issue of independent chain pharmacies. If in fact our goal is to get data that is more geographically and demographically representative of New York, we would need to actually have more independent, smaller pharmacies report, because in a lot of outer borough or less heavily urbanized, concentrated parts of New York, there aren't as many chain pharmacies. So that is something that we need to actually have an ongoing discussion with these large chain pharmacies about. With the large, the sort of over umbrella organization, which represents organizations that have more than a few pharmacies, not necessarily the Duane Reads and Walgreens of the world. Does that answer it?
And Dr. Foreman,
well, sort of. I guess I'm wondering if you have a strategy going forward for how you're going to continue to evaluate this and the importance of possibly requiring reporting from pharmacies in the future.
Yeah, so our first meeting with this group, just to specifically get onto the issue of how many pharmacies is actually occurring this week. So it is something that we are going to be tracking carefully. We were very firm with them when we met with them, and after we met with them, and we made a decision as a group that this is the type of regulation that we would gladly re-propose to the board in the future if their proposal to work on this voluntarily doesn't actually proceed well.
And just one more thing, if I may, can you report back to us in 6 months or whatever the appropriate time frame is, just to let us know how it's going?
Yes, absolutely.
Thank you.
We just need to take note of that here.
Thank you, it's noted. And may I just ask and follow up to that, and then turn it back to Foreman, did you get any further commitments from additional chains to voluntarily report data, or are you expecting to go forward with the same number of chains?
Not yet, so no one is committed yet, so that's what we're starting to do right now. So, and I think our discussion with Tom and everybody else in terms of general counsel was the idea that there wasn't any downside necessarily to us, because we don't view this as an emergent thing. We didn't expose a deep problem that needs to be fixed immediately. Rather, this is a concern that we've had for a long time, and we had decided now had been the time to do it because we had some discussions at a lower level with staff. So our sense is that we can always re-propose this before the board, and of course we'll certainly follow up and give you an update on discussions.
Great, so we'll have follow-up in 6 months, and Dr. Foreman.
Thank you, Commissioner. I just wanted to comment, I'm impressed with the changes that were made to these regulations in response to the comments, both written and verbal, that I think are productive. And I just want to say that I like the strategy here for the reporting because, as you said, there's no urgency at the moment. This is a powerful emerging tool that we don't quite know yet the full capability of. That being said, it looks very promising, and you gave us some really interesting examples about crypto and allergens and asthma in the spring that are exciting, but a voluntary route here seems like a great opportunity. And obviously you still hold back the option to proceed with a more regulatory approach if there's not better participation. So it seemed like a good public-private partnership, and I was impressed. I was also impressed, by the way, and I think great move to make the change around blood bank reporting. Obviously, that's what these sort of interchanges in public testimony is about. So thank you.
Thank you. Dr. Richardson.
First, I'd like to thank you for pulling the administrators of hospitals and other healthcare facilities on the hook for the attending physicians around the isolation of infectious cases. But I wanted to ask about the decision to put a 1-year time frame on the TB reporting. And I understand in a perfect world there would be positive sputum, and then the patients would be treated, and within 30, 60, 90 days everything would turn positive. But knowing how this often actually works with people falling out of treatment and so on, I wonder if a year is long enough to substantially avoid the work that initially I think you were trying to minimize with this proposal. Can I just ask you how you came up with a year? Is there some sense that that's magic touch? I often see people in the emergency department who were diagnosed the year before and were treated for 2 months and that now have been off treatment and so on. And if a negative sputum is obtained and could be reported to you, you could sort of stop searching for them, et cetera. So is a year long enough?
Yeah, I think the answer is that there is no magic number, and so we tend to stick with units of time that are sort of generally accepted as being meaningful. And so we thought 1 year represented a legitimate compromise between having them report results in perpetuity, as well as being within a frame that would likely to give us positive results. I think the point is also that it's 1 year after people continue to be positive. So if they are culture positive 3-6 months into treatment, that set point would refer to their last positive results. Let me pause for a second. Do you guys have anything else?
You're right.
Okay.
Are there any further questions or comments from the board? If not, may I have a motion to adopt?
So moved.
And can we put it to a vote? All in favor?
Aye.
So we have all ayes. Thank you, Dr. Varma. We're now moving on to a resolution to amend Article 47, the code regarding daycare services. This was to correct a drafting error.
Good morning. Martha Robinson, Associate General Counsel. There was a comment period that expired on April 21st. There were no comments received, so I would ask the board to amend the code accordingly.
Motion.
Move to approve.
Can I have a vote?
Second.
Oh, do we have a second?
Yeah.
Now may we have a vote?
Aye.
Aye. All right, the ayes have it. And we now move on to our last item for today's meeting, which is a resolution to amend Article 141 regarding water tank inspection records. And we have, please can you introduce yourselves?
Hello, my name is Trevor McBride. I'm a city research scientist with the Bureau of Environmental Sciences and Engineering in the Office of Public Health Engineering.
And I'm Dan Cass, I'm the Deputy Commissioner for Environmental Health.
And we're here today to present for a notice of adoption to amend Article 141 of the Health Code concerning building drinking water storage tank inspections. To go over a little bit of background of water tanks and the regulations and maintenance requirements. There are approximately 10,000 roof tanks for drinking water in New York City residential and commercial properties. And these are in buildings over 6 stories and required to supply water pressure above that which is supplied in the New York City distribution system at street level. And building owners are currently required to annually conduct inspections of the interior and exterior of the tank to sample water and have that water of those samples analyzed for bacteriological water quality at state certified laboratories that are certified to conduct potable water quality tests, and to report within 24 hours any exceedance of bacteriological standards for fecal coliform or E. coli positive results, and to remediate as necessary any unsanitary conditions that are observed during the inspections or at any other time, and maintain records of the inspections and testing, and to provide to the department upon request. And to go over the proposed changes, it would authorize the department to promulgate rules requiring annual submission of inspection reports to the department or a designated agency on a form provided by the department. And the goals of this change are to enable the public to learn whether a building owner has conducted annual inspections and testing, and enable the department to gather and post compliance information for all buildings with water tanks throughout the city. And to go over some of the board member comments that were addressed in the March 11th meeting on whether or not to publish the notice of intention. There was some concern expressed over regarding that the burden on building owners is excessive given the absence of known public health risks and the body of evidence of sample results over the years. And after consideration, the department would say that the incremental increase in burden is not excessive, and this is mainly because the proposed change is simply a change in reporting mechanism as opposed to anything in terms of what goes on in the inspection or what is required by the inspection or sample collection. And that affirmative reporting requirements would add minimal additional costs given that the records are already produced and the results are already taken as required by the health code and the administrative code. And the department is already authorized to obtain these inspection results upon demand, and this is just simply requiring the active submission without the department requesting it. And the department believes that this incremental burden is beneficial, and the benefit outweighs any burden that would be any burden for any of the building owners. And an additional comment was whether or not the health code should continue to require inspections and water quality testing given the absence of any known public health risk. And our response would be that the annual inspection is required by the administrative code and parts of the health code that aren't under consideration with this proposed requirement. We received multiple comments, written and testimony during the public hearing. To go over some of those. excuse me. Public advocate Letitia James commented that the risk of harm is too great and the amount that we spend for clean water is too high to not adopt the proposed changes. And additionally, that requiring building owners to report to the city is a minor burden that is clearly justified by its benefit. The Natural Resource Defense Council commented that New York City residents should have confidence in their water supply and faith in city officials are doing everything possible to protect it. And additionally, that the city should not jeopardize the reputation of the quality of the water due to shortcomings of inspection rules or poor practices by building owners. The Department of Environmental Protection Commissioner Emily Lloyd commented on the proposed changes, stating that the department supports the goal of ensuring that required inspections, which are preventative in nature, are being performed, and that the proposed changes make inspection compliance more transparent to the public. And New York City Council members Dan Gorodnick, who is the chair of Committee on Economic Development, and Corey Johnson, who is the chair of the Committee of Health, submitted joint comments on the proposed changes, stating that the building residents across the city will more easily be able to assess whether building owners are conducting annual inspections of their building's water storage tanks, and it will also assist residents in evaluating the water quality of their drinking water. There was one critical comment on the proposed changes. It was submitted by a representative of a laboratory that is certified to conduct potable water quality tests in the state of New York. The comment was that the sample results should be submitted electronically by the lab performing the tests rather than from the building owner to the department. And the department will consider whether this is appropriate and feasible, but without additional time and public comment, is not prepared to require this at this time. With that, I'll let Dan speak.
I just want to add, I was just handed a note by our Associate General Counsel, Martha Robinson, indicating the word is missing from one section of this, so I should bring that to your attention should you move to adopt, which is in 141C, titled Record and Record Keeping. The first sentence should read, the annual inspection report required by subdivision of this section shall be maintained by the owner, etc. So the word report is missing between the words inspection and required. Thank you.
So we should amend that. Yes. Are there any comments or questions? Are there any comments or questions from the board? This was the subject of spirited discussion at our last board meeting.
Thank you. Can you give us a sense of what landlords will be given, what instruction about how to do the inspection and what, if any, testing to do?
So just to reiterate, the testing and the inspection requirements are existing. Those aren't changing.
Okay.
We have information on our website about these requirements. They are conducted by, they're mandated to be required by a certified plumber, certified master plumber.
Licensed master plumber or companies or firms that are specifically permitted by our office to conduct inspections.
And should this be adopted, I think what we would say is we will engage in rulemaking. The intent of which would be to provide very detailed instructions about how we expect to receive these reports. And so there are a variety of approaches under consideration, but the essence of what we'll require is the submission of electronic or paper records that demonstrate the compliance with both the inspection and the water quality testing, and sort of fundamental information about whether any remedial actions were taken. We'll request it in a manner that enables us to fairly rapidly and accurately turn around those results into some web-based reporting that people would then be able to search at a building level for whether it's been provided.
So, do I understand this right? There are two parts of the inspection, a physical inspection of the condition of the structures, and then also testing of the water quality, is that correct?
That's correct, yes.
So are there instructions now to plumbers or owners about the water quality testing?
Yes, there's nothing codified in terms of the health code, but our office does, when we do grant permits to companies to conduct the inspections, we go over with the representatives what is required. We make sure that they're doing the correct inspection. We review their inspection checklist or inspection form and their certified inspection report, and to make sure that's sufficient information.
So I think part of the discussion last time was, given that what data we have do not suggest significant public health risks from the water quality, what are you thinking about in terms of future water quality testing of the tanks?
So we're not anticipating any changes in the water testing requirement, both because we think it's a reasonable expectation and because it's already mandated in the administrative code as well. So we don't think that there's a dearth of information about how to comply. We expect that, and our own survey efforts have demonstrated that at a minimum there's inadequate record keeping demonstrating compliance. Does that help answer your question? The testing results are effectively not changing under this proposal at all.
I understand that.
Okay.
Thanks.
Dr. Carroll, and then Dr. Foreman.
I remember in one of the hearing an argument that the plumber are the one doing inspection. Are they really capacitated to do evaluation of the structural things that are more for an architect, an engineer?
Yes, I think licensed master plumbers should be and are capable of observing and reporting on all of the necessary structural features of a water tank that's necessary to protect the water quality. There may be some rooftop. The scope of our inspection results are primarily what impact the water quality, so that may not be all of the structural features of a water tank. It's mostly the roofs, the hatches, the specific valves, and pipes that are connected to that, whether or not they're functioning properly.
I would also just add that there are building code requirements for these water tanks, and where there is a significant change that's going to happen to those, they have to file building permits, and those are then evaluated by a host of other people with engineering and other skills to evaluate everything from the support to the design.
And Dr. Foreman.
Thank you. I had a few questions, but just to follow up on that one, there was a comment, I think, by a company that does inspections, suggesting that if the people doing the inspections didn't have the capability to address the problems or remediate, that they shouldn't be doing inspections. I actually just want to say I disagree with that statement. I think just the opposite is true. There's a potential for conflict of interest if the only people who can inspect are the people who can fix. And an example would be lead-based paint and dust. There are plenty of inspectors who don't do remediation for just that reason. You get an honest appraisal and then you shop for the appropriate firm to do the remediation. So I thought that I disagreed with that one comment that was there. And then a couple of other questions related to it. I think asked last time was the idea of costs. Do you have I didn't feel like you got a good answer to what does it cost on an annual basis to do this? And the other related to that was there was a comment from, I think a professor from Rutgers in New Jersey, who talked about the EPA suggesting that actually there should be more frequent inspections than annually based upon health concerns. And I wondered if you could comment on those comments and what you thought about his suggestion of more frequent inspections.
Well, in terms of the cost, we did some analysis and contacted both building owners and building tank companies that perform the work. And after surveying several different sources, we determined that the average cost of cleaning, or I guess cleaning a tank is sort of a separate issue, but the range for simply a bacteriological sample, which is the primary piece that's required by our health code, is ranges from $100 to $350, depending on whether or not other sample parameters are being conducted beyond the simple bacteriological test. And then cleaning and repairing and fixing a tank can vary greatly in cost, but that's something that's driven more by either the Department of Building Code or other inspections. Yeah, and these are based on invoices from building supplied by building owners or management companies, and from invoices from various water tank companies.
And in those, we see that typical inspection cost would be in the several hundred to $800 range.
So the estimate of $15,000 to $20,000 would suggest that that must have been quite a major repair to the water tank, not a simple.
Right, we don't know. That certainly would be a very typical charge for an annual inspection and test.
It's often the case that cleaning, which is required by the Department of Building, is done at the same time as inspection and sampling, which is required by our department. And a fairly common number that we saw is a water test for $100 and cleaning for $680 to $750.
And the suggestion about more frequent inspection? Did you see that comment, and what did you think?
I have to admit that I didn't specifically see it, so I'm reacting sort of instantaneously, but I think that, given that we have neither received a positive lab report as we would have been required under our health code, nor have we seen, based on responding to worst case scenario complaints, any samples that have demonstrated these things, I'm not sure that we have basis for suggesting that the inspections be more frequent. There are, I think I mentioned at the last board meeting, that there are conditions, climate, weather-related or even building-related, that may alter the integrity of a tank. Many times, under extreme circumstances, those would likely be known to a building owner, and they may initiate their own inspection based on that kind of event, a hurricane or a windstorm or an ice storm, or known complaints from within the building of cloudiness or smelliness in the water. But I don't think that there's a basis in evidence for a more frequent inspection.
Can I throw my last two quick
Please
ones?
do.
That there was several people that suggested public posting, and I heard you mention website availability of these inspections, and certainly that does allow the public to monitor what's going on, similar to the posting of letter grades that are accessible very easily on the web and on smartphone devices. Were you thinking of a similar approach? And then my last question to throw out there is, several people mentioned epoxies, and I think getting at the potential for either plasticizers or solvents or other things that might contaminate the water, and I wondered if you had a comment about that.
So let me take the first one. I'll start with the last one. We are looking at the reports of particular chemicals being used or epoxies that might not have been cleared. My understanding is that one of the ones in question is actually undergoing an evaluation for appropriate use of these things. Our expectation is that, given the actual physical condition of tanks, given the extensive use, dilution, replacement of water, that even sort of modest amounts of unapproved products are unlikely to pose a significant risk to people. Epoxy, once cured, is in fact cured and inert, and so the principal hazard really would have been at the time of introduction prior to curing into the water supply, and that would be an unlikely scenario. That said, we do have rules about these things, and we'll certainly do our best to enforce them and to notice them. Refresh my memory what your first question was.
The method by which you would post the results and how accessible they would be.
So the health code already requires that building tenants be notified of the availability of these results. We don't find that to be a particularly effective strategy, nor do we necessarily think that posting a sign in every lobby will draw people to review them. The practice of posting inspection results in New York City across agencies has moved toward one where it's available electronically, where there are buildings violations and inspection results, whether the Housing Preservation Department's inspection of the housing code, whether our own inspections of child care facilities or restaurants, all of these things are making it onto the web. They're very popular, they're heavily utilized, they generate a lot of both interest, and they also help people understand exactly what we do and why, but also to drive compliance. So we think that's the right strategy, and our rules will certainly reflect once we publish them and you authorize us to do so, our rules would certainly be designed specifically to enable us to do that in an expeditious way.
Thank you.
And Dr. Galea.
Thank you. I apologize I wasn't here last time I was traveling. I'm sure I would have enjoyed that meeting. I just have a question about the last comment. I have some sympathy with the last comment that he showed us in, from the public hearing about why not go to the labs.
Yeah.
And I'm sort of struck, and unfortunately this suffers by contrast with Dr. Varma's previous presentation where he made a compelling argument that going to the labs is the right way to go. Is there any reason, I realize I'm mixing apples and oranges, but is there, I understand you don't have time to think about it, but would there be any reason why in the fullness of time going to the point of testing would not make sense here?
So I want to clarify why we said what we said in terms of our response. So the first is a procedural one where because we did not propose it initially, we couldn't just come to you now and ask you to adopt it, so we didn't receive public comments on that. Second, it may well be a very good way to do it, and we may, in the end, get more complete reporting by doing so. But we don't think it's warrants delaying action, and it's certainly something we can revisit. Now, if were we to receive a lab report separate from a building owner's report of inspection and the physical and visual inspection, we would have to find some way to basically merge those things. That is not quite so simple as it is often for medical records, because there is a medical record that usually carries forth from the point of treatment or diagnosis to the laboratory that is then imminently leakable. It's not typical for a laboratory to maintain a building identification number, which would be the proper linkage for taking a lab report and merging it with the building department. So we need to think about how to do that. We would need to talk to laboratories about whether they have the capacity for recording a bin number, and were it to be absent, how they would go about looking that up, which is, it's doable, but it's certainly not a typical thing for a laboratory to do.
And these are certified labs and all that.
That's right.
So it's more of a mechanical question.
That's right.
Thank you.
I had just one clarifying question. Am I right that we can still trigger inspections by complaints if there are concerns about the water by a tenant, for example, independent of the annual inspection process? Can you just remind us?
Yes, absolutely. Any complaint that we receive in the office regarding water quality issues and which may be health related, we respond to oftentimes by taking a sample at the end use, point of end use, which is in the residence faucet, whether it's wherever they specify it or whether we think is the most likely place to take it.
Thank you. Are there any other questions from the board? A final question,
One
perhaps?
final one. There was suggestion that the department should do more testing, random testing on its own. Obviously, that would have a pretty big burden on inspectors going out, and that the number of tests the department has actually done over time is actually not so huge. So I wonder if you could comment on that and whether or not you thought there really was a need for more aggressive testing by the department as opposed to just reporting of testing by buildings.
Again, I'll go back to my statement earlier, which is I don't think there's a basis in evidence for the demand for more water testing on our part. We will go out in response to a complaint, a water quality complaint, and we'll evaluate it. That's the source of the information we presented the last time about the number of tests that have been taken in response to that, and the fact that none of them have returned a positive fecal coliform or E. coli test result. Now that said, part of the intent here is to drive compliance, whether it's improving record keeping or whether it's actually increasing the number of tests and inspections that do occur that may not be currently doing so. Once we have these data, which is part of the goal of an affirmative reporting requirement, we would then be able to do affirmative actions in response to those buildings that have failed to provide the records. And that may not be an inspection, but it would certainly, at minimum, be a notice to the building owner to comply.
Thank you.
And do we have any further comments or questions from the board? If not,
Yeah, well, I think we're on the same page. I really have enjoyed this discussion as well as the last meeting, and I thank you for getting back to us with some data about the cost, because I think we were all shocked by the figure that was thrown out by one of our colleagues at the last meeting, and we're relieved to hear that this is not so burdensome on owners. So I would like to move adoption of the proposed rule.
and may I have a second?
we have a motion for to amend as.
We need to first have a motion to amend.
Move to amend as recommended by Council Robinson.
Second.
Do we need to vote on the amendment? All in favor?
Aye.
And now, we'll turn to Dr. Richardson's.
Move to adopt as amended.
And may I have a second? All in favor?
Aye.
Thank you very much. The motion carries, and we are now at 10:53. I get to use the gavel. We are adjourned.
Well, you are excited.
I think that's the first time I heard the gavel.
Yeah. That was excellent.